All right. Welcome back, everybody, to the Invisible Podcast. I am your host, Dr. Ashton Wilson. I'm an osteopath, and I host this podcast every odd week, I suppose. I like to think it's every week, but, let's be real. I'm a neurospicy person with a lot on my plate. So it's when I can, but I have got myself a fabulous guest today. And joining me all the way from WA, Western Australia, I've got Dr. Kai on the line.
Hey, how are you?
Very good, thanks. Now, Dr. Kai is a chiropractor joining us from Perth, correct?
Yeah.
Yeah.
I moved.
Yeah, so good. So Kai and I connected via Instagram, which is how I meet most of these wonderful people interested in the hypermobile space. We connected just over a year ago, and Kai actually came to the course that I hosted over in Perth. And yeah, we just got along like a little house on fire. So it's great to have you on the show and to come and share a little bit of wisdom from the other side of the country.
Yes. Different country.
I mean, I've got a sister-in-law and a brother-in-law over in WA, and they insist it's a different country.
It is. It is.
So what have you been up to, Kai? Tell us what you've been doing.
I've been busy in clinic, seeing lots of hypermobile patients, found that is my area of special interest. And then in my spare time, I've been doing lots of gardening and just trying to keep up with day-to-day life.
It's a good time to get into the garden with the spring just around the corner. I think, I know that spring is coming because my allergies get so much worse.
Oh, 100%.
Waking up in the morning and immediately sneezing, I know that spring is just around the corner. I've got to double up on all my antihistamines and it all happens. So yeah, I completely relate. But so you mentioned that you've been busy in the clinic. You are a bendy gal just like me, and you have fallen into working with the hypermobile population. I like to think you've manifested your way into working with them. But tell us a little bit about your story and how you got here.
Yeah, so like many bendy girls, I didn't know that's what was going on for many years. So as a kid, wasn't the most coordinated, kind of a clumsy person, not very good at sport. It wasn't until probably around 10 or 11, I started sailing, found my passion in that, got hyper-focused on that. And then being so passionate about that sport, I went and did it all the time. Had a back injury around 12 years of age, wasn't able to then sail for 6 weeks. So looking back, that's pretty flaggy for a hypermobile body to injure yourself at such a young age. And then after that, did that sport for a while. Then fast forward probably 2021, I got diagnosed with endometriosis. So that was the first for my diagnosis. And with that came a lot of different health concerns that kind of followed, because it does link in all those little trios of conditions. There's like multiple trios with bendy bodies, as you probably know as well. So that was the first kind of diagnosis. And then it kind of went from there. I then got ADHD in that same year. Then 2024, it was a few years later, went into the ED, appendicitis, got told I didn't have anything wrong, got sent home. 4 days later, I then ended up going to an urgent care because my mum was like, no, something's not right with you when she was visiting, which great timing when a mum's visiting you, definitely. And then got put in an ambulance from urgent care to the hospital. They finally then did a CT scan and I had appendicitis. So after that's when all the POTS symptoms started. And that's kind of when I then thought about MCAS and hypermobility. Yeah.
And you're right in saying, there's all these little connections, because what we understand now about connective tissue disorders like hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder is that wherever there's connective tissue can be affected by a connective tissue disorder, which is why all these issues that seemingly seem unrelated are actually connected on a connective tissue level. So it's so interesting that from your own journey, you found yourself in this space, working as a chiropractor and working with hypermobile people. I'd really love to dive in a little bit deeper with you, though, into that first diagnosis that you got of endometriosis. And I guess there's been some really cool research coming out somewhat recently, diving deeper into endometriosis and the links with hypermobile Ehlers-Danlos syndrome, hypermobility spectrum disorder, but as well the links with mast cell activation syndrome. So tell us a little bit about what you know and how you piece these two together.
Yeah, so I think with endometriosis, at the time, probably when I came across POTS and MCAS and the ADHD was more like it's very common for a neuro spicy person, as we all probably know listening to the podcast, that it's quite common in that kind of trio. So I didn't connect endo and hypermobility until a little bit further down the line, but so common for women to have pelvic floor like issues, tension, all the things with hypermobility as well. So that was kind of one of the flags where I thought to myself, oh, potentially. But with endometriosis, there's a lot of kind of research now just coming out. And as we know in the hypermobile space, it isn't an area where a lot of people have researched historically. But women's health in general hasn't been something we've historically researched either. So I think I have some numbers here as well, but like 6% to 23% of EDS patients also have endo, which is multiple sources for that one. I can send those to you if we need as well. But then also some studies have found that 57% of endo patients meet the criteria for hypermobile spectrum disorder as well. So for HSD, which is pretty large number as well there. And then pelvic pain is present in 80% of hypermobile EDS patients and 66% for HSD. So we've got that really quite a large, broad data range there as well. But I think for me, the symptom-wise, it was all the like heavy periods, the pain, the cramps that were more than most. Like it wasn't a bit of discomfort. It was literally me sitting on the couch as a teen, crying, not able to go to school, bleeding through pads, like all the things that no young girl really should be going through or even experience, but a lot of endo women have. And I think that was the first signs of endo, but then the connection was thinking, well, it's a tissue inside your uterus that then the endometrial tissue is growing outside your uterus. It's a connective tissues kind of links in my mind. So that was the first kind of, connection for me there.
And it is, you make a really valid point there about a lot of women in general living with painful periods. I think it's something that we normalize from a very young age, that periods are painful and you do bleed a lot and it happens to everyone. But I'm a big believer in helping especially young women and young girls understand that no, that's not actually normal. And we need to investigate this better. If you're having a period that is so heavy and so debilitatingly painful that you can't get up off the couch, there's something wrong with that. That is not a normal part of life. And we need to be better at acknowledging that, I think. And I would agree with you on the connective tissue level. I see it's one of the screening questions I ask for a lot of my patients is, do they have any known history of endometriosis, adenomyosis, or PCOS/PMOS, which is what I was diagnosed with. That was my first diagnosis I got at 23. So, I think actually asking about these questions and screening for them is really important, because even as people working in allied health like yourself and myself, we're maybe not the best place to treat things like endometriosis or PMOS or adenomyosis, but recognizing the signs really early and understanding that link between hypermobility presenting to us in a clinic and then the connective tissue links to things like endometriosis, you can start to piece together the puzzle for someone to get further investigation and to get a better understanding of what's going on with their bodies. I think as well, the really interesting thing I found a couple of years ago, I read a paper that was talking about the links with mast cell activation, and it was a preliminary trial of trialing H2 blockers, so things like famotidine, trialing that for patients presenting with endometriosis to see if it helped with their pain and with their other symptoms that they're experiencing. And as a preliminary trial, they actually found that it did show signs that people were improving, and that is now an area that's being further investigated, which is this link between mast cell activation syndrome and endometriosis. Do you have any thoughts on that kind of area?
I think with the fact with mast cell activation syndrome, I was reading some research about that only yesterday, because I was going through all the PowerPoint slides from the EDS World Conference as well. And it's like your mast cells are the cells in your body that are meant to be your immune system. They attack when anything that's not meant to be attacking your body is coming in. But when you've got mast cell activation syndrome, they're switching on for things that it shouldn't. So it's that chronic inflammation. And I think with endometriosis, they're now figuring out it's actually a real inflammatory disorder as well. So I think between mast cell activation the fact that H2, it was H2 you said, wasn't it? Yes.
Yep.
Yeah. So like those H2 medications can then help with the mast cell activation we've found. So it would make sense potentially that it could be helping with that endometriosis symptoms as well. I think it's not confirmed yet, but that is the kind of proposed connection between there. It's that immune dysregulation, the chronic inflammation in the body. But I think what they haven't figured out is why all of us are getting to that point. Yeah.
And that's, I guess, the biggest gap in research, isn't it? Is this, and we know, and it's been well publicized this year that, it's only recently we've been studying female bodies as part of standard research.
I know. Crazy, right?
Yeah. Like even like female mice weren't being considered in mice models because hormones would interfere with the research, which is just bizarre to think, isn't it? That we have all of these conditions that primarily affect women. The conditions we're talking about, HEDS, HSD, that's 80% female, 20% male. We know that from research. Endometriosis, a condition that affects born females with a uterus.
1 in 7.
1 in 7 women. It is such a high percentage of women. And it's a thing that, we just have no answer for. The same could be said about so many conditions like lipedema, another one that we're just starting to understand a little bit more. Migraine, another one that affects primarily women. We're looking at all these conditions that affect women and we don't have the research, but we need it. We desperately need it because women deserve answers. And, the pain that we put up with, it is just not okay. It is not normal and we shouldn't normalize our pain. And I think that that's where, as clinicians like yourself and myself, being able to validate someone's experience, that, you ask them the question and you screen for things like endometriosis, PCOS, PMOS, adenomyosis, pelvic floor pain, heavy periods, all of these things, you screen for it. And then you help them understand that, okay, you're coming to me with joint hypermobility. Let's talk about how this could be connected to what you're experiencing in your pelvic organs. And I think that that's such an important part we have to play because although, like I said, obviously we can't diagnose these things because still our only form of diagnosis for endometriosis is still laparoscopy. Although I did read that there was that saliva test coming out, which is just bizarre.
And the blood test as well is in the works, I believe, where they'll be able to do a blood test and be able to go, yep, there's the presence of endometriosis. But whether that then means it's the presence or they know there's lesions, not quite sure. And I think that's where they're trying to figure that out at the moment. But it is cool that they're slowly getting kind of more accessible testing, because when I first myself went to a gynecologist, it was I'd gone to ED for the 100th time with the period pain pretty much, but it's unbearable, or an ovarian cyst bursting. Tell you that's not fun either, as you would probably know.
No way.
Yeah. And it was one female doctor in an ED one night who went, this isn't right, and referred me to a gynecologist. But even the gynecologist, after she did the internal and looked at my ultrasounds and everything, went, I'm not quite sure if you've got endo, but the only way to know is to cut you open and see what's inside. And I'll never forget, I went in, and because everything she'd said before kind of seemed like, you're not going to have it. Like, it's just we're doing this as a formality, really. Went in super scared. I remember my mum came up from the country to be with me, took me to the day surgery. We had to go at the earliest time. I think I was like 7 a.m. because I was first off the surgery list. And I thought I'd been there for an hour or so because I thought she was going to cut me open, have a look, go, up, nothing there, close me up and send me home. But I came out, woke up, it felt like that to me because, of course, anesthetic. But then I remember asking Mum how long I was in there for, and Mum was like, oh, it was more than 3-4 hours. And I was like, well, they must have found something. But you didn't actually get to see the gyno that day. So you go home, you've been given your list of what to do and not to do and all the things. And then it wasn't until the next day, I'm just thinking it might have even been a Friday. So it could have been a few days before I got the call, but I think it was the next day. And she went, you, my friend, are riddled with endometriosis. And those words, like, you are riddled with endometriosis, like, I don't have a good memory at the best of times, but I remembered that. So I think the fact that, like, women have to go through literally a surgery to confirm that they've got a condition isn't right.
No, and I completely agree. To that level of investigation to actually identify that you have a condition that is contributing to your pain. It's like the epitome of a journey of just gaslighting, and then you get to the end. It's like, oh well, surprise, you've got it. It's like you knew that all along, and I think that that's where, I see our role being, maybe the first people that can help a patient understand that this could explain why they feel this way, that validation is really, really important. And I don't think that we can undervalue how important that role is in the healthcare system because, yeah, we can't do the laparoscopy and we can't do the blood test and we can't do a saliva test, even if it's available. That's not our role. But our role to be able to help our patients understand that no, that level of pain isn't normal. And yes, there are investigations we can do, and I'm going to support you through that. That's just so important because I think, there's a common theme with the people I talk to on this podcast is everyone's gone through their own journey to get here. And we kind of use that to, power ourselves forward and to give more to our patients because we know firsthand what it was like to hear those words, right? You hear the words you're with endometriosis, that is like a sting. That has got weight to it. That kind of hurts a little bit to hear it. I remember my PCOS diagnosis was in a similar dramatic fashion to you, was walking into my doctor's office and being handed a pamphlet that said polycystic ovarian syndrome, and then sitting down to read it. I was told to read it. And then I was told, okay, you have polycystic ovarian syndrome. You may always have trouble getting pregnant. Here's a test for diabetes. And that I remembered walking out being like, okay, I'm 23 years old and I don't even know what's ahead for me, but now my life's been determined. So I think that that's where as well, our words, we need to be so, particularly with the words that we choose when it comes to talking to our patients, because, those words, they stick with you and we don't want them to define you, right? Like those words they're just words and we need to be really, really cautious with how we use them when we're talking to our patients. Yeah, look, we could talk about endo all day because, and women's health in general all day, I think, because I can see you've got a massive passion for it. But I'd really love to hear a little bit more about your approach with hypermobility as a chiropractor. Now, I will preface that you are not like every other average chiropractor. There are some incredible chiropractors that I know, and you are one of them. And I think you and I have had discussions before about probably one of the main differences between our practices is the time that we get to spend with our patients. So, for me, I spend well over an hour with most of my patients. And for you in the practice that you work in, you are confined by a little bit of a shorter time frame. So as a chiropractor working currently under a different chiropractic model, how do you then work with the hypermobile population? Like, how do you utilize your time and get the most out of your sessions with your clients?
I think with being a chiropractor, traditionally it is shorter appointment times, and there's some that are very, very short and some that are now operating on more of that osteo kind of mindset, physio mindset time appointments. But I myself work in a clinic where we do 10 to 15 minute appointments. I do that for, I'm going to say it's kind of morphed into not even being half of my patients, because a lot of them I want to give exercises, even if they're not hypermobile. I want to give exercises, some kind of lifestyle advice, and doing more than just an adjustment, which I don't want to take away from the power of an adjustment, because as a chiropractor, the power of the adjustment and the nervous system side of that is like incredible. But the fact we can also do more, like the lifestyle advice, exercises, dry needling, cupping, even just hands-on soft tissue release, like I like to personally add that in. So a lot of my patients, I will do what we call an extended consult. So most of them I'm doing in 20 minutes now, but I think key is making sure you're doing the screenings for all these conditions, because we know, like we've already spoke about today, like the clusters of kind of conditions, endo, PMOS, MCAS, neurodivergence, then obviously hypermobility as well. I feel like I'm forgetting one in there, but as you know, they all kind of go, oh, there we go. Yeah, I knew. I was like in my head, yeah, the main one that got me into this area. Jeez, that's neurospicy right there. But I think kind of knowing, and like if you see on someone's intake form, oh, they're on Vyvanse or they're on DEXIs, like knowing the medications, and that's you're kind of in. So if I see someone's got Vyvanse, I'm like, okay, they're probably ADHD. And then bringing that up in your medical history, but also screening with females coming in with lower back pain. It's like all in the screening, I find. And there's some great questionnaires. Like I know in your MCAS episode, you mentioned, I cannot say it either. It starts with the F,
The frog.
yeah, I'm like the mast cell one. Yeah. Like having those screening questionnaires, I have a folder of them in clinic where it's like an endometriosis kind of screening one, but also one where you can just gauge their symptoms over time as well, and having the POTS one and MCAS and all the different questionnaires, like, and even the hypermobility, like diagnostic criteria list, like having that in clinic. Yes, a lot of it isn't within our scope in that we're not with the mast cell one doing the bloods or the imaging and everything, but being able to fill in the first half of it with a patient or have them do that in your waiting room and help with any questions. And they are able to take that to their doctor and you're able to put that into a referral. I find that's where our primary, like being an allied health practitioner, can kind of help in really being that pillar in supporting them through that. So I think it's all about the screening, because then you know whether you need more time with the patient. Long-winded answer there, but yeah.
That's a brilliant answer. And I couldn't agree with you more. I'm a big fan of those questionnaires. I have a bunch of them saved to my computer. And then if I detect that someone through my screening, fits the category for something like this, I'll say, okay, I'll send you that after. You complete it, send it back to me. Because this is something that, we want to prioritize the time we have together. And this is something that will help us better understand which direction we need to go. And I love that, Kai, because I think even your, the detective work you're doing through their intake form of looking at their medications and understanding that medication means ADHD, or that medication means that, maybe they've got a beta blocker for some kind of heart thing, maybe it's POTS, understanding that those things are clues, that is being a curious practitioner. That is taking it to another level. And I think with the time that you are spending with your patients, you're really maximizing that time together. And that's just really awesome. Now, you did mention in there a real hot topic that you and I have discussed quite a bit before, but it is the idea of an adjustment. Now, both of us are trained in performing adjustments. We learn them at uni. So you learn them obviously as a chiropractor with your spinal model, and we learn them as an osteopath, both spinal manipulations and peripheral manipulations.
Yeah, we did as well. Yeah.
Yeah. And they are great techniques to learn to create mobility, I think. And, like you said, there is that neural element and that analgesic element as well. So it helps with pain relief. But I'd really like to hear your take on how you utilize adjustments and how you rationalize using them with a patient, or how you rationalize with a patient when not to use them. I'd love to hear your take on that.
Yeah. Like we already spoke about this just before today as well, I think it is an ever-evolving space for myself, because a lot of the time as a practitioner and talking to a lot of practitioners, it's kind of, you have to use your medically trained intuition. And I have a 90-year-old patient. She's the most gorgeous old lady, but she comes in and goes, use that intuition of yours, Kai. And every Wednesday morning. But I always correct her and say it's my medically trained intuition. So because we've had those, I don't know how long an osteo degree is, but Cara is 5 years, and I did it part-time whilst competing in sailing. So 7 years for myself, 5 years for most Caras, where you're going through how to be safe, how to know what to do and when to do it and when not to. So I think that is all the training that you've got in your hands and in your mind and your feel and your palpation skills. So you're able to then kind of gauge. But I think it is just also knowing that a lot of hypermobile bodies, if a joint is moving really well, you probably don't need to introduce more movement into it. I think that's where chiro does differ a little bit from osteo, in that I'm not sure though, because there's probably osteos out there who do it as well. We're kind of all overlapping nowadays, but excuse me. But I think that's when I go for those lower force techniques if needed. So some patients have come to myself after seeing other chiros and they're like, you know what, when I get my neck adjusted, I just don't quite feel like it's right. In my body, I just don't feel comfortable. And I'm like, a big believer with any patient, and this is a big one that not every chiro will agree with, but I'm sure there's osteos out there who wouldn't agree with it too, and even physios, because they can manipulate as well if they go do the training. But I'm a big believer in if a person's not wanting an adjustment, you can feel it in their body, especially with their neck, but even their lumbar, like in their lower back. And my mother-in-law is a classic example of that, and she just knows intuitively that her neck and her low back shouldn't be adjusted. And I think that's key. You don't have to do that. We've got all these other tools in our toolbox. There's no point in trying to convince someone that they need that. So yeah, I think it is just the idea of if something's moving well, you don't really need a manual technique. Let's go to those lower force activator, blocking, drop piece, muscular sort of things as well, even though that's a whole nother ball game. And even just releasing the traps on a hypermobile person, like that's a whole nother ball game we can go down another day. But I think it is using that kind of gauge and understanding that the same patient, I have one patient who's been diagnosed hypermobile EDS as a child, which amazing that she got diagnosed. She's around my age. So like 26, 27 years ago and getting diagnosed at a young age is really great. But obviously she had the really, really big flag symptoms back then as well to get diagnosed. But me and her, she's a nurse, so we talk quite a bit. And the way your body can present one day with your shoulder subluxing every 5 seconds, but then the next week your shoulder's not moving at all. So I think it really is up to the practitioner, and probably yourself would be similar in this area, but it's you just feel how the joint is moving that day and then decide what you're going to do.
Yeah, I think that being able to use your clinical judgment is really important. And I think you made a really good point there on consent and actually explaining to your patient why you're doing what you're doing. Yeah, you look, I know a number of practitioners, osteos, chiros, physios, who have done all sorts of things to patients I've seen treatment-wise to obviously do something. But I don't know that they really had the intention of what they were trying to do in the first place. And so it's one of the things I teach in my courses. If you're going to do a treatment on someone to treat something, you better well be able to justify why you just did what you did. So if you're going to stick a needle in the upper traps, you better be able to justify. You need to justify why you did that. Because if that person reacts poorly, if the upper traps is the only thing contributing to the stability of their neck and you go and deeply release it and then their neck really hurts afterwards, you better be able to justify why you did what you did. And I think the same goes for adjustments, where if you're performing an adjustment of a lumbar spine that is already moving incredibly well, why are you doing what you're doing?
Because probably not going to be able to get it to lock out anyway.
And then you're using an exceptional amount of force to create a cavitation, which is the popping noise for anyone wondering what a cavitation
isn't scientifically needed either. It's not the adjustment at all. It's just what we all, I think, patients of osteo and chiro alike, but like, yep, there's meant to be a popping noise. Cool. Yeah. Even when a physio does your thoracic mob, it's like, oh, that popped. That's nice. And it does make you feel better in your mind as a patient because you're like, oh, that released. It's that kind of oxytocin. But
yeah,
it's not the required thing at all. Yeah.
No. And I think that we need to, as manual therapists, I think we really need to be justifying why we do what we do, not just doing things for the sake of it. And I always think about, particularly with hypermobile bodies, hypermobile bodies are just a series of compensations. They are compensation after compensation, desperately trying to create stability. So if you do something that challenges that stability without doing something to support the stability, so maybe something active, maybe something to engage muscles, you better be able to justify why you did what you did. Because I see it a lot where, I'm not saying that manual therapy doesn't have a place. It does, and I still use it. But, it's using it with intention. What am I trying to create out of doing this thing? And is this person going to be able to, stand up and walk out of my room if I massage their glutes, or if I massage their low back, or if I use needling or cupping or an adjustment through their thoracics? I think that for me, the idea of an adjustment, particularly, you need to be safe. So you need to be screening
100%.
all sorts of flags. So, anything. So obviously in the cervicals, we've got our craniocervical instability, which is really common in our hypermobile population. We've got then, other risk factors like osteopenia, osteoporosis, which can happen particularly for women who are like perimenopausal, menopausal. We've got other red flags like, rheumatoid arthritis, all these other things that can coexist with our hypermobile populations. We know that. So I think being able to effectively screen, you need to be able to really, really, really be good with your screening and then choose your techniques wisely. I always think if you can't justify why you did something like an adjustment, then why'd you do it? What was your
Definitely.
purpose?
I
Yeah.
think it's an ego one for us coming out of uni as well. I'm not sure with osteopathy as much, but with chiro, like the skill you've been taught to do is adjust with your hands. Like, yes, you can use all the low force techniques, but they're more you go and do the courses after, and then they're slowly kind of drip fed through your degree. But it's like the main skill is we're taught how to use our hands. Like, so then to not adjust someone, it can be a big ego thing. And you've got to then think to yourself, what do I actually need to do? And the power is our advice, our knowledge of everything actually is a skill in itself and valuable to the patient to be able to guide them through everything. Like if you're sitting and having to talk to the patient for a whole appointment, even I find myself, if I was to sit and just give advice and lifestyle advice for a whole 20, 30 minutes, I would feel, oh, but did I not provide value? Like almost, do you charge for that? But of course you charge for it because it is that knowledge and your skill and your time and all those things. But I think that is the power of what we can do. It's not just the hands-on therapy. And if you're
Oh,
adjusting
fine.
something manually, you need to be then backing it up, especially for a hypermobile body, like probably anybody, but majorly so with the hypermobile patient, because you then need to be helping, like you said, it's a array of compensations through the body. So you need to kind of pinpoint those compensations and be able to be like, okay, so we're going to do this exercise to do this. And you and me still probably both, well, I definitely do, have compensations through our body. We're hypermobile. We always are going to be like, so it's just a consistent journey and work in progress to kind of help your body through that. So the exercises are key, I think, and it is a difficult space when you are trying to educate patients on that as well, because they come to a chiropractor especially, they just want you to crack them, which they've been getting done for 10 years, some of them or more, and they feel great after it. And then they come back in 4-6 weeks and they have their maintenance kind of appointment, which I do think maintaining your body in the hypermobile, especially in all these chronic health condition space, is key. But you need the in-between stuff, the pain toolkit, which I learned off you. Like, it's just a great way to kind of say what we're giving lifestyle advice with as well. But all those little things that the patient can do in between the appointments is key.
Couldn't agree with you more. I think you hit the nail on the head there that, to summarize what I think, like you're not your hands, and it is such a like an ego driven industry that we're in, because in a way we help people, but we feel good about it. Right? Like someone leaves our office and they say, wow, Kai, I feel so great. Look at how much I can move. That makes us feel really good. We're in it because we want to help people, but there is that instant gratification we get from helping someone feel better. That makes you feel good. So there is a big ego element to, like actually understand, well, what does this person really need right now? Do they need my ability to adjust their neck, their thoracics, their lumbar? Do they need that right now? Or do they need me to help them understand that wearing compression garments is going to help with their POT symptoms?
Put them on whilst you're in bed before you're upright. Didn't do it this morning, silly me. But the little pieces of like even electrolytes, like the fact so many people with POTS don't know about electrolytes. And yes, it isn't getting to the root cause. Like there's a clinic, a chiropractic clinic actually in the US. I'm not sure if you've heard of them, the Kaiser Clinic. Yeah, they are chiropractors, but they're doing some amazing stuff. They even like use transdoppler ultrasound on the cerebral blood flow and everything as they like get people up in an active stand test. So like it's a really cool program they're running over there. And I kind of look at their stuff all the time, but their whole philosophy is like, well, electrolytes and sodium and all that is just kind of masking the deep cause. And I agree with that, definitely. Like we want to get to the root cause of what's actually going on with your POTS, but electrolytes can really help. So things like that, it's like a lot of us don't know about. So yeah, definitely we're in that space where we have access to the knowledge, so we need to share it.
I love that. I love your attitude towards allied health, and I've loved watching your growth as a chiropractor from a distance, and how you've really just embraced making, like almost utilizing your chiropractic skills and using it in your own way, and really you say you fell into this world, but I'm confident you manifested yourself into this world because the world needed you.
Because I was researching it all for myself anyway.
Nothing like a bit of me search to ignite something, right? Like, I think that, watching your journey as a chiropractor over the last few years, like, I think that it's absolutely a reflection of your dedication to health, but also to your patients and helping more people, more bendy people, get the help that they need. So yeah, I love that. Well, as we start to wrap up today, Kai, because this has been a really great chat, and I think something that I think will be really valuable to a lot of practitioners and to a lot of patients who are listening, because there's a lot of really great takeaways from here. What would be your top 3 takeaways from this conversation for our listeners?
It's funny. I had a list of all different ideas I was going to bring up, and we just go on tangents, don't we? Like, it goes so quick and we could talk all day. I think the top 3 for listeners. We're going to do a mixture of practitioner and patient, I think. So the first one is common does not equal normal. And that's something I repetitively put on my socials and say to patients. And it's like, well, period pain, just because it's common doesn't mean it's normal. Headaches, like debilitating migraines, common but not normal. Fatigue, which is a big one for all of us, bendy, endo, all the different things, like common but not normal. So all of those things, yes, I'm not sure about you, but with the fatigue, it's a work in progress journey as well. But just because something's common doesn't mean it's normal. And I think even as a practitioner, being able to address being fatigued, I feel, it happens to me too. Pacing, all the things, like that is what helps, but it's not normal to be so fatigued you can't get out of bed in the morning and having headaches and period pains. So addressing that and understanding that, like, you've got to be your biggest advocate for yourself sometimes as a patient. And it sucks and it's not enough, but it is what it is. And so just understanding, just because a lot of your friends might have period pain doesn't mean it's normal. Yeah.
That's one. What's your other one?
Oh, true. Sorry. Paused. ADHD much, like got into that one and was like, see ya.
It was a good mic drop moment, to be fair. Common but not normal. I think everyone's going to remember that.
I should have done that should have been my third and final, but I was sitting there the whole time after we mentioned it in the middle. I was like, that's one of my summaries.
Love it. Lead with the strong one. I love that.
The second one probably is as a practitioner, so chiro, physio, naturopath, like anything, like understanding you have a really, really important role. Like, I've had one patient recently, she won't mind I'm saying it, like after about 3 appointments, she came in for non-surgical spinal decompression therapy, which we've got a machine for. And it's getting a lot of attention because it's a new thing in Perth, which is great. And it's working for those disc injuries. But she came in for that. And with all her little history detecting, I was like, something more is going on here. I found she was hypermobile. So within 3 appointments, she said to me, you are the one practitioner who I've learned more about my body in 3 appointments than I have in all the years. And she's been to people, like many different practitioners. And it's like the fact that if more of us allied health practitioners had an understanding or at least an awareness around these conditions, because not everyone's going to be as passionate as you and I are, if they have an awareness around it, at least then you can flag it and go, okay, if you're in Melbourne, like a lot of people would know you're the hypermobility osteo. It's like all the other osteos, if they flag it and then can refer to you for that, I think that's key. So you actually can play a really vital role. And like hearing she'd learnt more in 3 appointments from me than anyone else, it's like, well, just taking that time, running 5 minutes late if you have to, like really is key. And it's kind of the importance and the value that we can provide, I think, that's what makes me quite passionate. And the third one, let's think here, I think it's going to be around the lines of advocate for yourself. But also, if you are a female who gets pelvic pain, one way a lot of endo, I always have this little question where I ask endo girls in clinic just to see, because everyone's symptoms, like in hypermobility, are so different and how they describe the pain. And one girl was like, it's like a screwdriver in your stomach. And I've always said it's like a knife in your pelvis twisting. So I think if you're getting those types of symptoms where you're using words like that to describe it, and it sounds crazy to say, like I get it. But if you're getting really bad period pain, it's probably not normal. Go see your GP, get a referral to a gynecologist, go to a women's health physio or a women's health chiro osteo or whoever, and at least get that opinion of it. And then also think about whether you're hypermobile, because there's a likelihood you are. And yeah, one of my patients says you get handed one diagnosis and you get handed a whole plate of them all. And it can be overwhelming, but I think just slowly understanding your body, the more you understand these conditions and understand your own body. But so the third one is, if you're getting terrible period pain, lots of body aches, like there's probably a deeper cause, and definitely investigate it.
There are some great takeaways right there. I think I couldn't agree with you more. I think, yeah, if you're using those big describing words, you need to get that further investigated. And for practitioners out there, let's do better. Let's be better. So, Kai, as we come towards the end of this conversation, this has been just such a great chat. It's so great to hear where your passion is for women's health, and I'm sure that there'll be lots of people who are keen to find you in Perth after listening to this. But before we go into how to find you, I'd love to ask you a few questions. Now, I ask all my guests these questions. So, what is one hack that has changed your life?
I was thinking about this one because as a listener of your podcast, I knew it was coming. And there's so many hacks, I think, when you are a bendy body. But I think the biggest one for me and where it kind of changed was when I had my chronic fatigue and I started actually scheduling in. This was before I even had any diagnosis, which upon reflection, big flag. But with fatigue, scheduling in white space to your diary so that you actually commit. And some days I'll have a white space afternoon and I'm like, okay, I'm going to do nothing. I'm going to lay on the couch and watch Netflix. Like, we all deserve a little couch rot every now and then. Other days I might be like, oh, let's garden, and I garden all afternoon, or I use it to catch up on life and then get myself. But being able to have that time where you're not committed to doing anything really is a peace of mind in the back of your mind. So it's your pacing and your spoons and all those things, which a lot of us know about nowadays in the bendy community. But it helps with your ADHD, your endo fatigue, your hypermobility, just having that time to do what your body needs and listen to your body for that as well is key.
That's a great hack.
Schedule white space.
More white space. I love that. And what would be one thing you would like to say to your younger self?
I think that eventually it all makes sense. Like laying in bed as a kid, and it was in our first house because we moved houses when I was about 7. So it would have been pre-7 is how my brain works in ages. And I would lay in bed and my mum would give me a piece of white bread at night when I'd wake up and go, I have pain in my legs. And everyone would just say it's growing pains. Like, oh, big flag, hypermobile. Like, painful periods, the not quite fitting in, all those different things. Like, it all makes sense when you get those diagnoses. So like, don't worry, all the dots will be connected. It all makes sense. And even in a way that like, it's where I've become a practitioner as well. Like, I think life has a funny way of figuring things out for you. Like, life happens for me. So it all makes sense in the end, but the dots will connect, and it won't make sense as you're going through the journey, but it all works out, and you'll connect the dots. Yeah.
Love that. And what is one thing you'd like to see change in the healthcare industry?
I think the healthcare system and like allied health and Western medical, modern medical world, like the system is overloaded in the hospital system, obviously. And I hear stories from patients like yourself, probably, because we see all these different people with all different conditions. And it's just, unfortunately, it's an overloaded system. But I'd like to see, especially in this space, like practitioners really doing their due diligence and referring when needed if it's not something you can help. But I also believe that like as an allied health practitioner, you still have that key component, even if you refer. So like refer to the people who need to be seen. And yes, it's expensive for patients. Trust me, I get it. I'm one too. But like a team, and we all actually work together. But also just having an awareness as an allied health practitioner or a GP, like in these conditions. Because unfortunately, there's GPs out there who don't know about MCAS, POTS, hypermobility. Endo, they probably do by now, but whether they actually think of it, because I don't envy GPs. They have so many things to know about. But like, even as a chiro, a physio, a musculoskeletal practitioner, or even a sports practitioner, you need to have an awareness of these conditions, not all the little itty bitty bits that make them up like you and I love to know, but an awareness to go, something might be going on here. I'm going to refer. Like, that's the power. Because imagine if any of the practitioners like myself. I saw chiros, osteos, physios as a kid. I saw many of them and got symptom relief, but like if one of them had just flagged it sooner when I would have been a lot bendier, like it probably could have saved me years of not knowing what was going on in your body. And it really does kind of help. And yeah, I think that's key.
Imagine a world like that. I love it. Thank you so much for joining Dr. Kai Taylor. It has been fantastic having you on the show today. Tell the listeners, how can they find you?
So on Instagram, I'm .kai.taylor. We'll put that in the show notes as well, I'm assuming. And then I'm also got a new Instagram account. Not many people would have found this one yet. It's literally got 2 followers because I haven't launched it properly, which is the Hypermobility Collective, which is just going to be a community for women in Perth, I think, is kind of, but haven't really got there yet. I just made the Instagram account, typical neurospicy, but it's kind of more community-based at first, yeah.
Love it. You heard it here first. Well, thank you so much, Dr. Kai, for joining us today. It's been fabulous to have you on the show. And to the listeners, thank you for tuning in. If you have any suggestions on who you'd like for me to speak to next, please send them through to me. You can find me on Instagram at doc_Ashton with 2 N's at the end. We'll see you next time. Thanks. Bye.